I kindly request our guest of honor, Dr. Irina Papiya, to address the gathering.
Good afternoon, dear ladies and gentlemen. This is a great pleasure and honor for me to be here. And I don't have formal presentation, and I would like to start my sharing with you my talking points with some personal reflections. When I joined WHO India 2 years ago, and I started to talk with different stakeholders in quality of care about what is happening here in the country in relation to quality of care, the first thing people were sharing with me were about, we have wonderful accreditation program in India. We have very good national body. We have very many committed people. So all the talks were started from accreditation. Recognizing the importance of accreditation in India and elsewhere in the world, and definitely respecting and welcoming all the initiatives that are going on in India, still quality of care goes much beyond accreditation. And I was very happy to hear that the title of the CAHOCON 2016, which is organized by Consortium of Accredited Healthcare Facilities, is what we have now. Quality of care beyond accreditation. So we talk about quality a lot at global level, at regional level, at country level, and I think we all are now very much convinced that we need to accelerate our joint action to improve quality of care everywhere. The issue of quality assumes much more importance within overall agenda of universal health coverage, as was mentioned by my colleague in the previous talk, which is nowadays considered as the most powerful concept in public health. However, what happened historically when we were progressing towards UHC, we were putting much more emphasis on equity-related concerns, on financial protection, leaving quality of care a little bit unattended. That is why, as a result, quality of care was neglected as policy objective. And nowadays, we are facing kind of new generation of problems, which is about transformation of problem of access to services to the problem of access to quality healthcare services. And this issue is particularly important in the developing countries where health systems, while expanding population coverage, should optimize their resource use. And that is why the process of improvement of quality of care and scaling up needs to be based on sound local strategies for quality so that the best possible results are achieved. Quality is multidimensional concept, and I think it was also articulated by previous speakers. Probably defining quality of care is the most difficult task for health system professionals, and one of the reasons for that is actually about the multidimensional nature of the concept itself. Quality is about access to health services that are efficient. It's about acceptability of health services or patient-centeredness alongside reasonable level of safety. It is about delivering effective care and in equitable manner. So in order to ensure all that, we have to ensure reasonable amount of inputs to the health system, like human resources for health, infrastructure, etc., in addition to some processes to be put in place, like good governance and financial management practices. So it's all about health system. So in this context, fragmentation and disconnect between different quality interventions, even very brilliant, that are going on in India and actually all over the world, is not anymore acceptable. And this is something that our organization, WHO, is strongly advocating nowadays. In practical terms, it means that any single quality intervention, be that accreditation, be that the standard treatment guidelines, be that enforcing regulations, should be seen within overall context of health system strengthening. And in some cases, it might involve even the fundamental reform of the entire health system. There are different approaches existent to conceptualize quality of care, and what is difficult nowadays is to find the best way which strategy to conceptualize, which strategy to choose in a given context. WHO defines 6 key domains of quality interventions that includes leadership and governance, organizational capacity, models of care, information, patient and population engagement, regulation and standards. These generic domains are not hypothetical, and they drew heavily on the strategies of quality improvement that were applied in many countries throughout the decades. And many countries emphasize only one domain while choosing some quality interventions. For example, accreditation programs, or more emphasis on the enforcing standard treatment guidelines, while others have chosen an adequate mix of approaches, taking into consideration local technical, financial capacities, political circumstances, variety of factors, etc. What is key here is to choose those interventions or mix of interventions that will be aligned with the overall health goals and would have the greatest impact on the outcomes delivered by the entire health system in the most effective and efficient manners. Another issue that we are having today is about evidence for quality. Research, we know, reinforces more scientific and systematic approach in the use of information for choosing quality interventions in the given context. But there are two issues regarding the evidence. First of all, global results that are available as of now are very much contextual, and evidence requires local interpretation by those involved in planning for quality. Diversity in practice makes published evidence even more contextual. For example, the use of accreditation program in different countries doesn't follow any standardized methodology, and that is why at the end of the day, the results achieved in many countries are hardly comparable to each other. Transferability of learning and experience is also contextual. It cannot be assumed, for example, that positive experience in quality improvement in one setting can be easily replicated in another, where there are different needs and major cultural differences. And in addition to that, we have to accept that there is no enough evidence as of now and impact of different strategies to address quality of care. And I think this is something that can be addressed by this audience. Why not to generate more evidence and convince our governments, central or state governments, that we have an impact and our strategies are effective, and then move forward, right? Another issue that I would love to emphasize is that we need systematic monitoring and measuring all interventions. It is very important to boost performance and ensure accountability among variety of actors. In practical terms, it means that any quality policies and interventions should be flexible enough to be adjusted at any time of point at implementation as soon as the needs comes. Also, what is critical here is that interventions are monitored at different levels: institutional, regional, country, and even global level, for which there should be just an agreement of key performance indicators. It is easily achievable in many countries of the world where there are reliable and well-developed information systems. But as was mentioned, I think, again, by some speakers in the previous session, there is an issue with information systems here in India, and this is something also that we think can be addressed again by you, by this audience. And as mentioned by Dr. Devi Shetty, that it is not necessarily that the center defines and chooses interventions and strategies. Sometimes it comes from the bottom, right? So maybe we together with accredited or not accredited healthcare organizations can define and agree on some key performance monitoring indicators, and then communicate that further to the state level, and then even to the national level, and then to the global level, in order to ensure comparability of Indian data with the data coming from all around the world. And my last message, which I think is the most important one in this context, is about importance of working together. There are multiplicity of actors. Again, this was discussed during first session, it was discussed during different gatherings, and besides of just variety of actors involved in quality improvement in India, the issue is also about different perceptions by different stakeholders and different roles and responsibilities. For example, policymakers definitely will be very much concerned with efficiency, while core responsibilities of healthcare providers will be to ensure that services they provide are of good quality, of high standard, and meet expectations of their patients. But health outcomes are not achieved only by providing of services by healthcare providers. Communities and service users also are co-producers of health, and they also have critical roles and responsibilities in identifying their own needs and preferences and in managing their own health with appropriate support from healthcare providers. While it is important to recognize the differences in perceptions and roles of different stakeholders, it is also very important to recognize the connection between them. Moreover, we have to recognize that at different points of time throughout our lives, we may employ totally different roles. Today, we are healthcare providers. Tomorrow, we might be health managers or maybe policymakers. I think by default, we all are, sometime become patients or represent a patient's family, right? So, in simple words, quality of care should be everybody's business, and only by accepting and recognizing the importance of working together and accepting the different perceptions will lead to the better and effective results. Thank you very much.